Now introduce our second speaker, who is Dr. Mohan Jambugulam. Dr. Mohan Jambugulam is an associate professor of Christian Medical College and Hospital in Vellore, India. He completed his postgraduate training in internal medicine at CMC Vellore and subsequently underwent further training in toxicology and occupational medicine at Paediatric Hospital. And at the CMC, he is actively involved in the clinical care of patients with poisoning and envenomation, undergraduate and postgraduate medical education, toxicology research, and poison information activities. It also includes chemical safety training and community outreach activities. And he has additionally contributed to national level training programs in India on management collaboration with the Ministry of Family Welfare in the government of India. So today he will deliver a case-based discussion of plant poisoning in children. Dr. Mohan, the session is now yours. Over to you.
Thank you, Professor Kavinda, for the opportunity and kind invitation. So today we'll discuss about an interesting case about plant poisoning. So the title is How Plant Tox Albumins Act as Potent Cytotoxins, an illustrative case of Jatropha curcus poisoning. So in India, of all the deliberate self-harm cases that we see, 6 to 15% are due to the plant poisoning. And many of these victims come from rural areas. And these are the common plant poisons that are encountered in Indian emergency departments, mostly oleander, Vodavanthalai, Nux vomica, Datura, Castor, Gloriosa superba, Abrus precatorius. And these plant poisons contribute to wide spectrum of toxicity profile among these cases. So when we analyzed our data in 2024, based on 2024 call data of almost 22,000 calls, 1,400 inquiries were made regarding animal or plant toxins, and of which about 600 were regarding plant toxins. So when we analyzed what are the various plant poisons of 616 inquiries made, majority were related to oleander poisoning, followed by miscellaneous or other plants, then Vodavanthalai, then we have Datura and mushrooms, and some are due to Abrus precatorius and Jatropha plant poisons. So just to start off with the basic introduction, so here is a case about 2-year-old boy from Vellore. That is where our poison center is located. Developmentally normal with no significant past personal or family history. On day 1, he presented to emergency department with 6 episodes of vomiting, 4 to 5 episodes of large volume loose stools. And day 3, he developed diffuse abdominal pain, abdominal distension, and also developed breathing difficulty. On day 4, at presentation, he appeared very lethargic with complaints of poor feeding and further worsening of breathlessness. So, followed by he presented to emergency department at CMC. So, initially he was receiving treatment at local hospital. When symptoms have worsened, on day 4, he presented to emergency department at CMC Vellore. So, on examination, he was afebrile. Visibly, he was in respiratory distress. There was tachycardia, 144 beats per minute. Blood pressure was low, 85 by 42 millimeters mercury. He was tachypneic with 50 breaths per minute. Peripheries were warm. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema noted. And there were features of subcostal and intercostal retractions present. And on auscultation, there were crepitations heard over right infrascapular and infraaxillary area. There was tender liver noted, almost 5 centimeter palpable below right costal margin. So, few investigations were done. He had anemia, 6.2 gram per deciliter, and total counts were elevated. And he also had elevated liver enzymes, and there is a mild derangement in prothrombin time and INR. Other investigations were within normal limits. And chest X-ray revealed there is right mid to lower zone patchy opacity, probably consolidation, or second, probably an aspiration pneumonia. So with that history and examination and preliminary investigations, provisional diagnosis was made that of acute hepatitis, probable viral hepatitis, probably an aspiration pneumonia was suspected. So these are the various differentials that we consider, and we did test for those also. So dengue serologies, IgM hepatitis A and B, and scrub typhus, hepatitis B, paracetamol levels were sent, and ANA also were sent. All were below the, all were in normal range. Child was treated with antibiotics for probable aspiration pneumonia, and cause of acute liver injury could not be ascertained. That is when, from Paediatrics department, Poison Information Center was contacted and clinical toxicology consent was sought. So we have seen the child and history was revised, and these are the various differentials that we also consider along with already considered differentials. So target review of possible toxic exposure to agents known to cause acute GI symptoms and acute liver injury were considered. So this could be what is called a cytotoxic effect of poison. So like, for example, iron can cause this cytotoxic effect, where in children it is very common where accidentally ingest iron supplements and develop initial GI symptoms. And in severe cases, they can develop liver injury with multi-organ involvement and with severe lactic acidosis. Second possible differential considered was phosphorus containing rodenticides like yellow phosphorus, metal phosphides were considered, which again present similarly. Herbal products and supplements with various cytotoxins that are present also considered. Child was given a laxative. So an important history that we could get it from the family members was that the same child was given a laxative paste for constipation that was prepared by grandmother one day prior to symptom onset. So what grandmother actually did is she made a paste by grinding almost 20 brown colored ovoid seeds from a plant, and she also added slaked lime, and it was fed to baby every 6 hours with milk for one day, which is supposed to have a gut cleansing effect. That is what their belief. So followed by child developed these symptoms and presented 4 days later to CMC emergency department. So we also reviewed the samples of the seed and the paste left at home. This is how appeared. So these are the seeds that they showed us, and this is a paste that they prepared from these seeds by using slaked lime, which is what fed to the baby and developed these symptoms. So which was later identified as Jatropha curcus. So the discussion is going to be about Jatropha curcus with toxalbumin. First of all, if you look at Jatropha curcus, what actually it is, it's a plant that contains hard-shelled seeds which are highly poisonous by containing an important toxin called toxalbumin, which is present inside the embryo, which can be released when these seeds are made into paste or crushed and ingested by children or adults. So that is when an important component, toxic component called toxalbumin or curcin can be released, which is known to cause significant toxicity. So as I said, the most important toxic component of this Jatropha curcus is called toxalbumin. So Jatropha curcus, if you look at all parts are potentially toxic. Seeds are more toxic, contain several potent toxalbumins. The most important being curcin and ricin, which is similar to castor plant. I'm sure in Sri Lanka also you would have seen. This is a plant which is present everywhere, widely present across Indian subcontinent. So it is easily available for village people living in rural areas and access to these seeds, and hence there is increased risk of toxicity developing from the ingestion of these seeds. So there are various other plants that contain seeds and other parts which also contain various toxalbumins, not just the Jatropha curcus. For example, in India, we commonly see Abrus precatorius that contain toxalbumin called abrin. Ricinus communis has what is called ricin. Jatropha curcus has curcin and ricin. So these are the various examples of toxic plants that contain toxalbumins, which is an important toxic component likely to cause this kind of clinical presentation. So these toxalbumins are stored inside the embryo, which will be released when they are either masticated or macerated into the paste and ingested. Because of the tough shell that is present over the seeds, when children ingest intact seeds, it's very hard to get digested and hence may not release the toxalbumin and less likely to develop toxicity from these. Whereas if it is pasted, macerated or masticated, the embryo may get crushed and important toxalbumin may be released that can cause significant toxicity. Toxalbumins are highly resistant to high temperatures and they can withstand wide range of pH in the body, so that can cause toxicity when they are released in the body. So toxalbumins, if you look at chemical structure, it has two important components. It has A component, which is also called an active component we can call. Then B component, B is called a B for binding. So it binds to the receptors over the cell. So over the cell, it has affinity for glycolipids and glycoproteins. When somebody ingests, the toxoalbumin that is released goes and binds to these glycoproteins that are present over the cell surface. Followed by there is an endocytosis that happens so that the toxalbumin compound can enter into the cell cytoplasm first, where it will enter into the structural formation called endosome. So the endosome that is containing this toxalbumin, for example, ricin here, has three fates. The fate one, it can undergo what is called exocytosis. So the cell may just expel the toxic component called toxalbumin out of the cell. Or second fate is it may get ingested by the engulfed by the lysosomes and may get degraded and denatured, so that the effect of toxalbumin over the cell can be removed. Third important fate where it can contribute to toxicity is by entering into the Golgi apparatus, where after entering Golgi apparatus, will go through retrograde transport into the endoplasmic reticulum, where followed by it gets separated into A and B subunits. So A is the active component that we discussed, which will enter into the cytoplasm, binds to 28S ribosomal RNA of the 60S ribosome component. So by binding to 28S rRNA, where it preferentially binds to adenine at a position of 4324, where it depurinates, it removes the adenine. So hence, this depurinated rRNA is unable to bind protein elongation factors and protein synthesis will be ceased. So that leads to cell death. Once the cell protein synthesis is affected, many receptor function will be affected, finally leads to cell death. So a single A subunit can inactivate approximately 1500 ribosomes per minute, leading to rapid inhibition of protein synthesis. There are various other mechanisms are hypothesized of toxalbumins. It has apoptosis pathways. It can cause direct cell membrane damage. It can alter the membrane structure and function. It releases cytokine inflammatory mediators, also causes red cell agglutinating protein release, leads to hemagglutination and hemolysis. There is increased oxidative stress that can lead to increased migration of leukocytes to the site of injury. Finally, lead to poor tissue repair mechanisms and excessive fibrosis can occur. People who are exposed to these toxalbumin containing plant seeds are developing risk of developing long-term hypersensitivity reactions also. So these are the various toxins with similar mechanism of action that of toxalbumin. So whenever we see a child with this kind of presentation, where we have considered already toxicological differentials like iron poisoning, rodenticides, herbal products, we should consider other differentials like these diseases that I mentioned here, which act similarly. These diseases all have AB toxins. So for example, cholera has AB5. So 5 B units and one single A unit. We all know that by affecting intracellular protein synthesis, in patients with cholera can develop a massive diarrhea, massive watery diarrhea and severe shock and multi-organ involvement. Shigella dysentery again has AB5, one A unit and 5 B units. Again, it can cause crampy diarrhea, crampy bloody diarrhea and acute kidney injury. Tetanus, we all know, again has A and B subunits where it reduces or inhibits the glycine and GABA, inhibitory neurotransmitters in the brain. That leads to spasmodic contractions. So that is what they present with in tetanus. Whereas in diphtheria, again, A and B toxins can present with pseudomembrane formation, bull's neck formation, and other various myocardial and respiratory involvement. Botulinum again has single A and B subunits, which causes facet paralysis by affecting the release of neurotransmitters from presynaptic neurons. So this is very important to consider these differential diagnosis, toxicological and other infectious differential diagnosis in a child who presents with acute diarrhea followed by multi-organ involvement. So usually when toxalbumins are ingested, children with poisoning present in 3 phases. The first phase or local phase where mainly present with symptoms secondary to the mucosal irritation, or we can call it as a mild corrosive injury. This phase lasts for initial 6 to 12 hours. They can present with nausea, vomiting, diarrhea, hematochezia and colicky abdominal pain, which can lead to significant fluid loss, hypotension and shock. Following 12 hours of initial phase, these patients tend to have a asymptomatic phase where these JA symptoms usually resolve and patient appears to be improving. This asymptomatic phase can last for up to 24 to 48 hours or beyond, only to go on to an important phase called second phase or a systemic phase, where patient can develop multi-organ involvement, where they can have a significant hypovolemic shock, liver failure, direct liver injury, or a shock liver. Also can, based on each toxalbumin, they can have hemolysis, kidney injury, seizures, coma, convulsions, and cardiac arrhythmias, and severe lactic acidosis they will have and leads to death finally. So how powerful are these toxalbumins? Just to understand, these toxalbumins are very, very powerful. Just to compare with other toxalbumins, today's topic is about ricin and curcumin. Ricin is highly, highly potent. Median lethal dose is 5 microgram per kg IV is enough. Abrin, whereas 0.04 microgram per kg IV is enough to kill a victim. So these are highly, highly potent toxins to cause significant systemic toxicity. So we are all very aware of this incident where Bulgarian journalist was assassinated by using a tipped umbrella which contained this iridium platinum coated such a small pellet that contained ricin, and when he was shot with this umbrella, the ricin could enter ricin entered into his body. Within 4 days he succumbed to with multi-organ failure And later investigation revealed the presence of the small pellet that contained remnants of ricin. So we can understand that these toxalbumins are highly poisonous. So that's why in children, theoretically, even one seed ingestion can cause significant toxicity. So how do we manage? Usually it is a supportive management. Most important is being hemodynamic stability has to be achieved by considering adequate fluid balance and metabolic parameters, correction of metabolic parameters. N-acetylcysteine can be considered if there is liver involvement, can be continued totally duration of 7 days or till the liver enzymes improve. And in this child, the LFT significantly improved by day 4 post-admission and were first noted normal on day 17 of admission. Totally 21 days child had this illness and gradually improved and finally discharged. So these are the various therapeutic applications of toxalbums being tried, like they've been tried in immunotherapy and being used to deliver antigens into the cell, being researched in various neuronal degenerative disorders, and treatment of intractable painful neuropathies also being tried and being used as adjunctive in mucosal vaccines. So just to conclude my talk, toxalbumins are complex proteins. They are called AB toxins, act as ribosomal inactivating proteins. Accidental and intentional exposure to these poisons is common in children, especially in rural areas. They can present with acute gastroenteritis followed by severe shock and multi-organ involvement. Supportive treatment is what is a mainstay of treatment. N-acetylcysteine can be considered if there is a liver involvement. So it's very important to consider various other differential diagnoses when a child present with this kind of clinical presentation. So thank you. So if you have any doubts, I'm happy to take.
Thank you very much, Dr. Mohan, for that excellent presentation.